We are live.
Good evening, everybody. I welcome you all to yet another online iFocus session. Currently, we are running in the 54th cataract module. This is a master class, and today we have a topic that is 10 steps to a perfect SICS. Dr. Ragini ma'am is going to talk on this topic. Welcome, ma'am. Moderator for today's class is Dr. Kiran Kirtani ma'am. Ma'am has finished her MBBS from BJ Medical College, Ahmedabad, after which she did a MS from MNJ Eye Institute, Civil Hospital, Ahmedabad, where she received a gold medal. She finished a senior residency from DDU Hospital, New Delhi. Currently, ma'am is a senior consultant at Center for Sight Eye Hospital, New Delhi. She's a trained and certified femto cataract and refractive surgeon. She has been an organizing secretary of prestigious PG training program iFocus and organizing secretary of IIRSI. She's been a faculty with iFocus, IIRSI, and various other conferences. She's authored book chapters and publications in index journals. Welcome, ma'am.
Thank you very much, Dr. Kritika. And coming to our topic for today and our chairperson and the teacher for the class today, we are very, very lucky because both the teachers, both the chairperson, sir, and Ragini ma'am, have been stalwarts in SICS in this country and have trained thousands and thousands of students. So sitting in the comforts of our home when we are learning from these masters, we must consider ourselves extremely lucky. So first I'll be speaking or introducing our chairperson, sir, Dr. Kamaljeet Singh. Sir has done his MBBS and MS from MLN Medical College, Prayagraj. He has been HOD at the MLN Medical College and he was the president of IRSI UPSOS, and he has served as an editor in various prestigious journals. Currently, sir is HOD at United Institute of Medical Science and a senior consultant at Center for Sight, Prayagraj. Sir is chief editor of Ophthalmology and Allied Sciences, has been awarded by WHO Fellowship in Medical Retina, USA, and fellowships from Wills Eye Hospital, Philadelphia, and Massachusetts Eye and Ear Infirmary, Boston. Sir has published many books in ophthalmology, including the most popular small incision cataract surgery. Sir is an academician par excellence and a guest speaker of international repute. We welcome you, sir, to today's talk.
Thank you so
much. Introducing our teacher for today, Ragini ma'am. Ma'am has been the chairman of Scientific Committee of Bombay Ophthalmologists Association. Ma'am has performed more than 80,000 surgeries. Mind you, it's a huge number. There'll be lives and lives which we may spend, but we'll not be able to reach that number. So to be learning from her is a real great fortune. She has served and operated and examined in more than 500 camps in rural and tribal regions, worked diligently for leprosy patients and operated them for 18 years at Anandwan, the Honorable Baba Amte's ashram. Previously, ma'am was professor and headed the department at Sir J.J. Hospital, Mumbai, and served 29 years at Grant Medical College and Sir J.J. Hospital. Recipient of various awards, including 100 Women Achievers Award at hands of Honorary Shri Pranab Mukherjee, Honorable President of India. Ma'am has received more than 50 awards for community ophthalmology. I have myself been the fortunate person to have assisted her in life surgeries when she was visiting Center for Sight. And it's a marvel to watch her. I'm really grateful that we were able to see that, ma'am. Ma'am has demonstrated life surgeries of advanced phacoemulsifications many a times, and one of the few women in India who are actively doing so. She's presented papers and instruction courses as faculty at more than 50 times at major conferences in India and internationally at America and Russia. Ma'am has trained more than 1,000 MBBS students, more than 100 postgraduate MS students, nurses, medical officers. She's been examiner inspector for medical colleges in Maharashtra. She has been participated as invited guest in various TV shows on eye health and eye conditions. In the past, she has been the president of BOA and the Indian Intraocular Lens and Refractive Society. And when we asked ma'am to submit anything else that we could add, she very humbly has added, Manorama Netralaya is our step forward to continue to provide best and complete eye care to every patient with expertise. So not only the patients, the students are also fortunate to have you here, ma'am. Before we start with your lecture, I would request Kamaljeet sir to please say a few words and also introduce the topic for the students.
Small
And my respect to my teacher, Dr. Kamaljeet Singh sir. When I was very junior, he gave me the opportunity to operate at RIO because he is one of Lani sir's closest friends. I thank Dr. Mahipal Sachdev sir, Ritika, and Santosh Onawar for this opportunity and for the beautiful classes that you all conduct online. Thank you so much. Sir? Kamaljeet Singh sir?
What can I add on SICS? It's a long journey. When Dr. Mahipal and others were doing phacoemulsification, we were not having that machine with us. So we thought of doing a surgery which could be sutureless, self-sealing, and could reduce the astigmatism. So that was the reason we started doing SICS, and it became very popular very soon. And we came out with a textbook, and that also became popular. And then we had a close friendship with Dr. Lahane and Dr. Ragni. So we are a group of SICS people, keep on conducting courses and life surgeries, and we try to do whatever is best for SICS. It's a very good surgery, and many a times these days, when you mostly do phacoemulsification, this comes in handy in many hard cataracts. Otherwise, also, if you have astigmatism, you can counter that as astigmatism by the surgically induced astigmatism that you have during surgery. So, even astigmatism can be corrected with this surgery. Recovery is very fast, the results are excellent, corneal damage is much less. So with that much of introduction on SICS, I would request Professor Ragni Parik ma'am to please start it. Thank you.
Sir, only Ragini sir, आप गुरु हो तो मैडम नहीं हो सकते हैं sir. Thank you everybody. So, with permission from sir and everybody, can I start?
Yes, please. Yes, ma'am. Yes, Dr. Parik.
Is my screen visible? But this is not moving, huh?
The screen is visible. And
Yes. Now, can you see it? Is it visible?
Yes, ma'am.
Okay, great. So, like Kamaljeet Singh sir said, that SICS remains a very important part of our lives today. Out of the lakhs of surgeries that we do in India today, though we talk so much about phacoemulsification, more than 70% of these surgeries are done by manual small incision cataract surgery. So, what is the scenario today? The world today is that we want the cataract surgery itself is a catarefractive surgery. Patients want spectacle-free vision, simulation of natural vision. There is advent of flags and there are newer generation IOLs. So this is the scenario today. That is a fact. So we should be learning phacoemulsification, but can we learn phacoemulsification directly? Like Kamaljeet Singh sir said, there are places, there are instances like hard cataract and subluxated cataract, small pupils, and especially for postgraduate students, when you are beginning to learn, then it is very easy to learn SICS and take steps towards learning phacoemulsification. So SICS remains a very important part of our learning even today. Now, what are the basics or steps in an SICS? So the sclerocorneal tunnel. Now in phacoemulsification, the tunnel is a corneal tunnel, but here you are making a bigger incision because the nucleus has to be delivered. Any incision greater than 3.2 on the cornea will not be safe. So in manual SICS, it will be essentially a sclerocorneal tunnel. The second step would be capsulorhexis. The beauty of SICS is that you can do SICS, manual SICS, even without capsulorhexis. Now, when you are learning capsulorhexis, your rhexis tends to break. In mature cataracts, you have to do an envelope technique. So, in phacoemulsification, if you break the commitment to rhexis, then you break the commitment to phaco. But here you can do SICS even without a rhexis. Of course, doing a rhexis is our aim, and it is the best thing to do because you have to put the IOLs inside the bag, but it can be done without a rhexis. Hydrodissection and hydrodelineation, these procedures are just injecting fluid in the substance of the lens between the anterior capsule and the lens. This is to separate the nucleus because we need to bring the nucleus out for delivery in manual small incision cataract surgery. So these procedures are very, very important because if you do not separate the nucleus, then we can have the lens coming in, in an intracapsular cataract surgery. The next step would be that you need to rotate the nucleus to ensure free movement and comfortable delivery, because you have to remember in SICS that there is a nucleus inside the bag which has to be brought outside the bag into the anterior chamber and then delivered. So these are two steps which are separate, which must be remembered and carried out separately, but in confluence like a music orchestra going on to get a successful delivery. After the delivery of the nucleus, what remains is the cortex aspiration and IOL implantation. So these are the steps of surgery. Now, the first and the most important step is the conjunctival flap. Since we are making a sclerocorneal tunnel, we need to access the sclera through a conjunctival flap. What is important is that it covers the incision, so it will be constructed in such a way. And it also helps because the patient does not get irritation, and it is a very important step. Because once the conjunctival flap is made well and the wound remains covered, it is not only safe, but the second day you cannot differentiate if it is covered by the upper lid, whether the patient has undergone phacoemulsification or SICS. Now, this is the video which will show us the conjunctival flap. Now, when you make a conjunctival flap, I'm a left-handed surgeon, so you start at 2 o'clock. If you start at 12 o'clock, it will not be covered completely, and you make a fornix-based conjunctival flap using a forceps and the conjunctival scissors. And this is the making of the tunnel. Now, one has to remember that this conjunctival flap, after making it, you have to do cautery, but it has to be replaced back to cover the incision. As you can see over here, a groove was made and now the sclerocorneal tunnel is being dissected. So the conjunctival flap and the cautery are very, very important. And after that, you can make a tunnel, which is a modified round-shaped tunnel, and then dissect the tunnel with a proper crescent blade. And this is the entry into the anterior chamber. This is the extension which is being shown. So you know that you are seeing the construction of a tunnel. The tunnel is basically, as you can see over here, so we saw the tunnel and we will see the tunnel again. So after the conjunctival flap is made, you have to cauterize the vessels with a bipolar cautery. Now this is a sclerocorneal incision, which is a modified frown, which is made 1.5 millimeter behind the limbus. You have to be very particular with properly constructing the tunnel, because if the incision is not a frown or if it is concentric to the limbus, then there will be astigmatism. The proper use of instruments are very, very necessary, as you can see. So this is a funnel. As you can see, this is the scleral pocket which is there. What we are dissecting right now is the scleral pocket. The advantage of the scleral pocket is that it allows the internal incision to be bigger than the external incision, so that the nucleus can be molded and be brought out. This is the side port incision, which is constructed with the MVR blade. The 6 o'clock incision is used for the AC maintainer for the Blumenthal technique of cataract surgery. So the tunnel was dissected, and then now you are making an entry. Now, if this is properly constructed, you will see a dimple. So you go into the stroma of the cornea for some distance, and then you open it. This is a triplanar incision. The proper construction of a tunnel, which is a triplanar wall, makes it self-sealing, so no incisions are required, and it is extremely safe. So proper construction of the tunnel is very, very important. So after that, as you can see over here, the tunnel has been made, viscoelastic has been put, the pupil is dilated, and you are making a rhexis. So we can use a bent 26 number needle, which is easily available in all operation theaters, and the capsulorhexis is made. When you make the rhexis, you have to see that you leave and hold the base so that a rhexis can be properly made. So as you can see over here, you can make the rhexis also with, now here as you can see, this is a small pupil. Now in a small pupil, when you are making a rhexis, you have to remain within the pupillary border, because if you go under, you may not be able to see it. So you lift the flap. This is Dr. Lahane sir's video. That previous video was mine. I'm left-handed. So you leave the flap, then again re-engage it at the base and pull it in a circular manner. If you cannot do it with this, then you can use a Utratas forceps, which is very easy to use, very comfortable to use. This rhexis is done under BSS. So as you can see, this in a mature cataract, we have to do a dye-assisted rhexis, because in this cataract, now here the surgery is probably a phacoemulsification, but the idea of this video is to show the rhexis. So once you are staining it with the dye, then it is very easy. And here in a mature cataract, it is more comfortable to use the Utratas forceps. You have more control. But as you can see, you pull it like slightly circular, and again you pull it from the base. So that is very, very important in making the rhexis. So this is an important step. Now this is once the rhexis has been made, this is the hydro procedure. What is the hydro procedure? It is nothing but, as you can see over here, this is a golden ring. Now I can just pause this video for a second or show it again. So what is the hydro procedure? What you do is you take BSS in a syringe with a cannula which is 25 gauge, and you inject the fluid between the capsule and the nucleus, which is called as hydrodissection. And if the nucleus is soft and you go into the substance of the nucleus, it is called as hydrodelineation. Now the idea is to make this nucleus mobile. As you saw, we can start. So as you can see this video, this is the golden ring, which is the end point. The nucleus is slightly lifted up, and you are dialing it out of the bag. So which is extremely important for this step. So hydro procedures are extremely important, but one must remember that in posterior subcapsular cataract, no hydrodissection is done, only hydrodelineation. This is another video, as you can see, of a small pupil where a hydro procedure is done. So multiple points, small amounts of fluid are injected. You do not inject more, because, and you open the tunnel and do the hydro so that there is no pressure inside. If the amount of pressure and the fluid increases in a weak capsule, it can cause a PC rupture. As you can see, after that, the nucleus is gently rotated through the equator in a carousel technique, and it is brought out into the anterior chamber. Again, this is a very, very important step. So after this step, after hydrodissection or hydrodelineation is over, then you come to the nucleus management. Now, there are various techniques. There are so many postgraduates who may see this class, and they may learn the techniques from their teachers, which may vary. But what I would say is that learn various techniques and do what is best in your hands. You can combine the technique, but that technique has to be safe with regard to the ocular structures. And the next day, there should be no corneal striate keratitis. There should be no iridodialysis. You must protect the cornea with endothelium while they are delivering the nucleus, because striate keratitis means that that much of the endothelium is damaged. So use of viscoelastic to protect the corneal endothelium, which can never be replaced, is a very, very important thing in managing the nucleus. So there are various nucleus. First, you free the nucleus, you rotate and bring it into the anterior chamber, and then you can use various techniques to deliver the nucleus. So here we will see this is an AC maintainer. The nucleus is in the anterior chamber. You hold the tunnel. This is a glide. It is a polypropylene sheet which is easily available. By pressure and counter pressure, the nucleus and the epinucleus is also delivered. So as you can see once again, this is the glide. It is on the iris under the nucleus, pressure, counter pressure on the sclera, and the fluid coming in from the AC maintainer helps to deliver the nucleus. Now here there is a complete video which we can see starting. This is the rhexis, but this I think is a phacoemulsification. So I think that is cortex which is being shown. Yeah, so I think we can. This is cortex aspiration, so we can. Yeah, so we'll go to the next video, which shows us. So this is the whole video which shows us the SICS. The first is the making of the conjunctival flap. As you can see, very nicely you dissect it. Then make the incision on the sclera, which is a frown incision with a 11 number blade. The holding of the blade and pointing it in such a way that the tip makes the groove, which is half thickness of the sclera. You have to judge, because in some thin scleras, this is the making of the pocket, as you can see, which will make the incision funnel shaped. Funnel shaped. The internal incision, as you can see, is larger than the external incision, so that the nucleus can be delivered. But maintaining a small external incision helps to control the astigmatism, and the nucleus can be delivered through a small incision. This is the entry. You can see the dimple after going for some distance into the cornea. This is the making of the capsulorhexis, as you can see. And with the needle, you can use also Utratas. And the making of the side ports. Use of correct blades, 1.1 MVR blades is important for the side ports. Then you extend the tunnel, because this, so when you cut when you go in, and extend the tunnel with a 3.2 blade. So the different crescent blade, 3.2 blade, and MVR blade, the correct blade, and now the Indian blades are very good. So this is a cannula and hydrodissection. As you can see, this is a beautiful golden ring which is visible, and multiple points of hydro. The nucleus is harpooned with a needle and dialed and brought into the anterior chamber. Now we take viscoelastic, put it under, but here what we are not seeing is pulling this eyeball with the superior rectus or the bridle suture, which is very, very important in visco expression. We use the AC maintainer and the single flow cannula, which is named after Lahane sir, aspiration cannula, to aspirate the cortex. The beauty of this is that the anterior chamber is maintained. You can use all the ports. Now I'm using the side port. First, I was using the main port. So when you use the side port, removal of the 12 o'clock cortex is very, very easy. You can polish these fibers also, because the AC maintainer maintains the anterior chamber very well. and hence the polishing of the PC helps decrease the rate of posterior capsular. Under BSS, this three-piece intraocular lens can be now implanted inside the eye and it is dialed into position. What we see after this is hydration of the side port, which is a very, very important step to leave the wound tight so there is no leak. And you can see the tunnel is only 4 millimeter because this was a soft cataract. So small incisions can be made, and this step, placing of the conjunctiva back again and seeing that it remains there, is extremely important for a good surgery. So the take home message is to observe, practice, and learn. The correct technique is very, very important. And if you know your SICS well, we already know half our phaco. So it's very easy to perform this technique and to do surgery. So this is the last slide of the 10 steps to SICS. And we can go to the 10 steps of phaco after this if there is any discussion in between, so we can do that. Sir, Dr. Kiran.
Yes. Nothing more to add on this. Let's finish the phacoemulsification talk and then we'll compare and contrast.
Yes, sir. Yes, sir. Just a minute, sir. I'll just.
We used to do around 100 cataracts a day, and do everything is free. Still, people are not able to afford the foldable IOL. So 80% of our cases are either hard or very hard. So we have to do this surgery in any case, and the results are excellent.
So by the time ma'am starts with her next PPT, may I request?
Sir is here. I will have to leave and
Yes,
rejoin
sir.
again.
Good evening, sir.
I'll leave and rejoin again.
All right. Sunil ji, is that okay with us? Ma'am can rejoin us?
Because I'm not able to leave this presentation and come back with another presentation.
You can just open the other presentation and do the share. You can close the current presentation and then open the other presentation.
But I'm not able to close my presentation.
You should be, there is, just close the window. Or just simply open the other presentation.
ओपन करण्यासाठी डेस्कटॉप घेतलंय पाहिजे ना. हे बंद कसं करायचं?
It's so good to see Professor Lani assisting Dr. Family.
Ma'am, if possible, just open the other presentation and then share.
On the top left, there will be a minimization toggle. So then we'll be able to do that. Yeah.
We can see the presentation now. You can make it full screen, please. Thank you, ma'am.
Thank you.
Sorry for this. Now can you hear me?
Yes, ma'am, your slide is also visible and
Okay, can I go ahead?
yes, ma'am, please. Thank you.
Okay, so so what is important when you are learning phacoemulsification? So what is important is that the proper selection of a correct machine, a correct patient, trained personnel to help you, a complete setup is important, and you have to prepare for every eventuality. So whenever you are making a corneal tunnel, then you have to customize the site of entry. There has to be a safety valve, so the incision has to be triplanar. If it is large, then it will leak in the phaco and it will be difficult and it will create trouble. And if it is small, there will be a wound burn and the heat burn and the wound will be very tight. So whenever you are making an incision, square incisional geometry is very, very important. Now, uh, as you can see here, so here essentially the incision is different from the what we saw. Here the incision is a corneal tunnel because we are making an incision we are using a phacoemulsification where the incision will be only 2.8 or 3.2. So you make an incision on the limbus, then you can use a crescent blade to dissect the tunnel in the stroma. Many surgeons use only one blade to do this, but when you are a beginner, this is better. So you make the stromal plane and now the entry with the 3.2 blade. Correct? So this is a corneal tunnel, which is very different from the SICS tunnel that we saw. So here you can see that you have to maintain square incisional geometry. The wound should not be more than 3.2. Since it is the cornea, you cannot have friable wounds because the cornea takes time to heal. So you have to be very, very careful when you perform this incision. So the correct incision would be a corneal tunnel. Now these are the side ports for the use of the second instrument. So they are made at 90 degrees to the main port, two ports for the instruments, the AC maintainer or the chopper that you are going to put in. So these are the incisions which are very, very important. Once the incision is made, then you use viscoelastic to do the steps further, right? So now it is important that the side port incisions are two, but the correct size. The correct blades used are very, very important. They should be not very big because some people use Simcoes and all through the side port and make them very big. So that is not correct. So the blades have to be sharp to prevent detachments, membrane detachment. You have to make a 90-degree angle with each other. If the main incision is assumed to be at 12 o'clock, or say we are sitting temporally, then 10 or 2 o'clock. So, and so how? So when you put two instruments through the side ports, your your two fingers should make 90 degrees. That is how they will be correct. Otherwise, you will not be able to use your both hands comfortably. That is why these incisions should be at 90 degrees. Now, this is so here actually we are showing the side port in a SICS surgery, but what we are actually demonstrating is the side port, right? So we'll see that. So this is the sharp blade, MVR blade. So that the size is very, very small, just enough to put in the AC maintainer and the chopper. This was only for SICS that the 6 o'clock incision is made. This video is used as a representation to show how the correct side ports are made. So capsulorhexis, like I already said, it is integral to phacoemulsification. Break the rhexis and break the commitment to phaco. It is a circle of safety because your probe, see, we think that we must run around with the probe to get the nucleus. A good machine has followability, means the nucleus comes to you. So you must never roam around with the probe. The probe should always remain within this circle of safety. Because once you leave this circle, you are going to land into complications, which is a PC tear. And The rhexis enables in the back placement of the IOL, which is physiological. So this rhexis is integral, hence learning making a rhexis during SICS is very good, because there if you break it, it's okay. But once you have done SICS, once you have done lots of cases, and to begin with a well dilated pupil, immature cataract, is good to do a rhexis where you will be comfortably able to do it, see it, and perform it properly. So as you can see over here, this is the rhexis which we are doing. This is a well dilated pupil, and you can do the rhexis. As you can see that you have to move it curvilinearly and hold the base when you keep on doing it. So rhexis is very integral to phacoemulsification. After rhexis is the hydro procedure. It involves hydrodissection and or hydrodelineation. So in posterior subcapsular cataract, there should not be any hydrodissection, but hydro maneuvers are very important. Now in phaco, why do you want to do these techniques? Because it reduces the nucleus size, so the phaco energy used will be less. It provides a free rotating nucleus, because when you do a phacoemulsification, you need to rotate the nucleus to emulsify it bit by bit and aspirate it. Once you make a hydrodissection, you get an epinucleus, which is a buttress place for safety, keeps you away from the posterior capsule, and it enables complete cortical cleanup by doing the hydrodissection or the hydro procedure. So that is why this procedure is very, very important in phacoemulsification. So we will see this where the rhexis has been made. This is a small, as you can see, this is a soft nucleus, and we are doing a hydro procedure, multiple point hydro, so that you do not putting fluid, too much of fluid at one place. Phaco, after the hydro procedure, you have to do phacoemulsification. So you have to first plan the technique, whether you are going to do stop and chop, whether you are going to do divide and conquer, whether you are doing a straight Nagahara chop. So the most easy technique for beginners will be either the divide and conquer and the stop and chop. Now, the most important in phacoemulsification is the first division. The first division is when you divide the nucleus into two. So you have to choose the correct parameters, and you can take breathers to remove the probe and assess the situation. So this is very important, that you need not go in and keep on doing. If you feel you do not know, then you can come out, put viscoelastic, assess the situation, and then go ahead. So that is very, very important. Now, what is trenching? When you go inside with the phaco probe, it will emulsify the nucleus. When you make a gutter like this, so you go in and your movement, the nucleus is not one plane, it is an ellipsoid. So you must remember, and when you come back, you should not trench. The making of the gutter is called as a trench. You deepen the trench to 3/4 of the nucleus, only then it will divide. So the first trench and the first division is very, very important. You remain within the circle of safety. The periphery is not as thick as the center. So if the center divides, the periphery of the nucleus will divide. That is the mantra. So as you can see over here, so this is called as a trench. You go in and you just go, and with the forward movement of the probe, with the emulsification, this nucleus will get emulsified, and what will form is a trench or a wall, and then the nucleus will divide. So that is extremely important. This is another video, as you can see. This is, so you go in and you don't go in one plane. So you go down and then come up again. So this trench, you remain in the center. Do not go into the periphery, but the center is thick. If it divides, as you can see, the periphery will divide. So once the trench is made, you use the two instruments to make opposing forces, then it will divide. But one must remember that this wall must be thick. I mean, the trench must be deep, otherwise the nucleus does not divide. So once it divides, then again you can make 4 pieces. So what you are now watching is the stop and chop technique of phacoemulsification, where the first trench was made, the first division was made. and then you rotate this. That is why a free nucleus is very, very important, because you rotate this half, you bring it towards yourself, bring it towards you where you can emulsify it, and you make a trench over here also to help you chop it. Once the trench is made, use the chopper to separate the two pieces, and then the piece is emulsified one by one. So this is the stop and chop technique of phaco emulsification. As you can see, you have to bring the last piece towards yourself. Once the last piece is done, then you wait for some time before you come out. As you can see a little bit of heat burn. If your sleeve is not covering the needle properly, then you can have a heat burn, and or if the incision is tight. So one has to be careful. Now, cortex aspiration is done to prevent posterior capsular opacification. For cortex aspiration, you must learn how to use your side ports effectively. We use the AC maintainer and aspiration cannula, but if you are used the automated also, it is very good. We use the AC maintainer because it is safe, it is economical, it is reusable, and it is very easy to learn. Complete 360-degree cortex removal is possible. So as you see over here, so we can skip the steps to phaco, or we can see it also if it is not. This is the rhexis. As you can see, this is a cortex, which is a disc-shaped posterior polar cataract, making of the rhexis. So you have to be very careful over here. If you cannot make the rhexis, then you can use a Utratas forceps to complete the rhexis. So here we can see the making of the rhexis and completion of the rhexis. This is a hydrodelineation mostly, not a hydrodissection, because this is a soft nucleus, and then the phacoemulsification. So this is a very soft nucleus. It came without any, so here you can just emulsify the nucleus. Now what remains is this. So this is the AC maintainer, and this is the single port aspiration cannula. So you just gently tease it and you aspirate the cortex. So cortex aspiration is very, very important. Both these ports can be side interchanged. Like you can use the AC maintainer in this port also, and through the side port we can. So this main incision also can be used. The side port can be used. All these three ports can be used for complete cortical cleanup, which becomes very easy, otherwise would be very difficult. This is sub-incisional cortex, which has become very, very easy with the side port. Otherwise, it is very difficult to maneuver any instruments. Here, because of the AC maintainer, you can also polish the undersurface of the capsule, as we will see over here, and also the fibrils which are attached. So you can polish the posterior capsule and you can polish the undersurface of the anterior capsule. So while IOL implantation, be careful not to injure the tunnel, because a friable tunnel causes infections. You have to use the correct injectable systems, and you have to put the IOL inside the bag, and you have to position it after aspirating the viscoelastic in the bag. Okay, so that is very, very important. Now we will see. So this is the rhexis with the Utratas. So we can just run through the steps over here. This is the hydro maneuver going on, right? And separation of the nucleus. This is the phacoemulsification. You can see the cortex, some part of it in the epinuclear mode is emulsified, but we need not do this. It is safer to use the AC maintainer and the aspiration. As you can see, a complete cortical cleanup is very, very important to remove 360 degrees, because if this remains behind, the IOL can be decentered. Though it is inside the bag, it can cause decentration, and here you can, it does not cause inflammation. So complete cortical cleanup is very important. As you can see, there are some fibrils on the posterior capsule, which will now be removed and polished. This is a little bit of cortex which is remaining. as you can see. So you have to gently tease it. This is the polishing which is possible because the anterior chamber is deep. The undersurface of the anterior capsule polishing is also possible. So it decreases the amount of cells which can grow to cause the, and now the foldable intraocular lens can be put under BSS, or you can use viscoelastic. So putting the first loop inside the bag, and then gently the lens opens and dialing into position. Various systems like injector systems are available. They are not very difficult to use or put in the lens. So the most important part after this is the sealing of the tunnel, because if the incision is not hydrated well, the wound should be tight. So this is stromal hydration. What fluid was used for hydro, the same and the cannula is used. If by injecting fluid in the stroma on the side, at the side port incision and the main incision, for the first 24 hours, this hydration and this edema seals the wound till the epithelium heals and bridges the gap and stops growing. You have to assess the tenseness of the eyeball at the end of surgery, which is very, very important. So once again, observe, practice, and learn. The correct technique is very important. Selection of cases, easy cases initially, is the mantra. And what I would say is that you have to keep the patient's welfare first before you think about your learning. Learning is a stepwise procedure. Learn one step, perfect it, and then go to the next. And a happy patient always makes the surgeon happy. So I really thank you once again for this opportunity to present, and to give me this opportunity to present this class. And I hope that the students really benefited from. And if anybody wants to connect with me directly on my mail or whatever, I am always available to them.
Thank you so much, ma'am. You rightly said that learning is a step-by-step process, and it is also an eternal process. So we are all learning from you. We are all learning from our great teachers. Thank you very much for this lecture. We do have a few questions which have come up on YouTube. There are a few questions which I am also having for you and Kamaljeet, sir. Sir, would you like to first comment something, or should we first proceed with the questions?
Proceed with the questions, please.
Okay, sir. So, Dr. Krutika, first, would you like to bring in the questions which have come on our website or on YouTube?
Yes, ma'am. Ma'am, there is a question. And the question is, surgeons are having the problem in making depth of tunnel in SICS construction. So what they're telling is sometime in one side it goes superficial and one side it is deep. So they want to know how to make out the proper depth of tunnel, ma'am.
First, when you make the incision, that is why you have to use that sharp tip. You have to judge how sometimes the sclera is very thin, and the first incision you go through and through. So the half depth of that patient's sclera you can use when you are making the first incision, right? And when you are dissecting the tunnel, so what I did, I started at one, but I'm lefty, so you can start at one pocket and don't come out and do this. So just start and continue in that plane slowly, using a separating movement and not a cutting movement. And take the pocket and separate the stromal fibers, they will separate. So if you come out and go in again, you will change the plane. So do not come out. Start at one edge of the incision and go on using this technique, this dissection. So only the side of the crescent will cut, and then you dissect the plane so that you get one plane, and otherwise you get so many planes, and so one is superficial, one is deep. And practicing on both sides is really something which will help you learn this, because people or human eyeballs, when you are, if you have an eye bank and if you practice on the eyeballs that you get, people think it is really very helpful, because as you practice, you will get the feel of it. So that is extremely important, sir.
Yes, it's important to learn, and as I always see that there was a remark in that Mr. Lart's surgical book that as goes the incision, so goes the surgery. So it's important to make a good tunnel, and you must give maximum time for making the tunnel. Because if you have a perfect tunnel, the surgery will go smooth in any case. So these are some of the very important points Dr. Agni has told. Any other question if you have?
Ma'am, there is one more question. Is there any preference in making this scleral incision? Should we be using a 15 number blade, a 11 number blade, or can we use a crescent itself? Some people do invert the crescent itself and do the incision. So
I
which
would
one is
use-
preferred ideally?
So there are some people use the 15 number, some people use the 11 number blade. So I would say that you can use a 15 number blade or a 11 number blade to make the incision. Like when I use the 11 number blade, I use that tip which helps me judge the depth also. And the people who are using a 15 number, they just sweep the 15 number like this in a curved form. And so I find that making that curved frown is a little more difficult than making this reverse boat. We used to always make this boat when we were in school. So when you are 1.5 millimeters behind the cornea, it's very easy when you are. So one important thing is when you are making the tunnel, the eyeball should be your eyeball should be rotated slightly down so that it is you are able to see where you are doing it, and you make a straight line and give the back cuts. That is very easy because then making a freehand round geometric shape. So I use the 11 number blade. I have seen people using the 15 number blade. You can try with both. And what is best, which works in your hand and you are comfortable with. So try it on the human eyeball, which are research eyes. The eyeball is not used for keratoplasty, and where you can use it here with permission, or if you are using it on both sides and see what you are comfortable in. Both are good. I have never used the crescent and I wouldn't advocate it. But if somebody has used it, if one of your teachers is using it and teaching you, then that's fine too. But I would say 11 or 15, use both, and whatever works in your hand, you use that. I use the 11 number.
Dr. Kritika, any other question that we are having here?
Yes, ma'am. There are a few more set of questions. And one of them is one surgeon faces a problem of constriction of pupil while performing different steps of SICS. So how to tackle with this problem?
The pupil constricting when you are doing different steps. So one is that the pupil constricts. First of all, you have to start when you are learning with a fully dilated pupil. The pupil constricts because you are handling the iris. So while doing anything, if you're doing the side ports or if you're messing around with the iris, if the iris keeps coming out, your block is not good. So the pupil constricts because you're handling the iris. So your surgery has to be as iris free as possible. You have to see to it that, so when you're making the incision, you're going with the blade. If you're injuring the iris, then the pupil will constrict, it will become friable, it will come out of the incision. So the lesser you hurt the iris and the pupil, the lesser it will constrict. Use always flurbiprofen and tropicacil plus to dilate the pupil. That keeps the pupil fully dilated. If you are not using flurbiprofen, even without you doing anything, the pupil will constrict. Nowadays, phenocaine is available. If your pupil has constricted during any step, you can use phenocaine to again dilate the pupil. But if you handle the iris less, the pupil will not constrict.
Yes, ma'am.
So for that, you have to use a lot of viscoelastic so that the chamber doesn't shallow, and so you are remaining in the anterior chamber away from the iris.
Yes, ma'am. Ma'am, there is one more question. And the question is, if we tune with SICS, you can do SFIOL easily. What is your view about this?
My thesis topic was SFIOL. Okay, so now for now I would say that you have to learn everything. Everything. In today's world, you do SICS and then you do phaco. But of course, if you do SICS, then you have a bigger opening to work around, right? In phaco emulsification, you don't have a larger opening to go in and work around for the SFIOL. So definitely it makes your life much easier if you know SICS. Personally, like my teachers, Kamaljeet Singh sir and Lane sir and KPS Malik sir, every time we have courses and we go for each other's courses, we are strong. We are basically phaco surgeons. If I sit, I do 100 phaco, 50 phacos at a time. But I'm a strong advocate of SICS surgery. One must learn SICS surgery. It is not only good for SFIOL, but it is good for every surgeon where you can, like even today, if I have a cataracta nigra, I would close my eyes and do SICS and not phacoemulsification. And that is what I would advocate. So definitely it will help. The SICS tunnel will definitely help for an SFIOL. That is true.
And SICS is a test of your surgical skills, actually, how well your hand can handle the tissue and different tissue planes. So ma'am is right. It is quintessential that the students today, though they have access to most of the best quality phaco machines, and the phaco machines are only evolving. However, SICS is going to bail you out in the toughest of situations wherever you land up in them. Ma'am, in that vein, I have a question for you and Kamaljeet sir both. First question is, what are the situations or what are the specific indications where you would prefer a temporal SICS tunnel as compared to a superior one? And would you advocate that? That's number one. And the second question is, if we are already doing a phacoemulsification through a corneal tunnel, and we find ourselves in a situation where we wish to convert to SICS, what would be the ideal method to do that conversion? Whether to close that corneal suture and take another site, or to extend somehow, and how to convert in such a situation.
Can I go first, sir? So the first question was that whether I have ever done a temporal sclerocorneal tunnel. So that is if you have a superior bleb and you cannot do a phacoemulsification, you are in a place where the patient, like ideally, if there is a bleb, I ideally would not do a temporal. And sometimes, I have done it because, when I've started the incision and I want to do a sclerocorneal tunnel, I am at a camp and I don't have phacoemulsification. The superior cornea is very thin because the patient has probably had old scleritis and I cannot make an incision there. So I'm already on the table and I have to change the site. So I go slightly temporal by compulsion, because that superior site is just not available to me. I am at a camp where I'm doing only SICS and I have already started surgery. So that is during compulsion. Given a choice, when I've examined the patient and all in such type of situation, like where there is a superior bleb, whether there is superior scarring, because if there is a superior thinning, I would rather go with phacoemulsification. These are the indications where patients of old scleritis are contraindications for SICS and they are indications for phacoemulsification. But I am scared to do an elective temporal corneal tunnel, sclerocorneal tunnel, just for some astigmatism because they are exposed to the environment. I like my tunnel superior and nicely sealed and covered by the upper lid, which I find very, very safe. The second question was if you have to extend. I have done both. So you can extend the same incision by backward cuts, because if you have to, there is a PC tear, or so you have to remove the nucleus, and you can do it that way. I would advocate, see, if you are temporal, seal that incision, take a suture, put lots of viscoelastic, go superior, and make a second tunnel. But even though, because then again an incision will have to be made. So just extending the same incision backwards and expressing the nucleus is very, very good enough. I have done it in many patients, but the most important thing is that it needs suturing. It needs proper suturing with 10-0 sutures, because here there is a corneal tunnel and these are the back cuts. So it has to be sutured. There will be some amount of astigmatism. 6 weeks later, suture removal will help with that. So you have to be careful. So both work. The best and the scientific thing would be to close the first incision and make a new sclerocorneal tunnel superiorly.
Kamaljeet sir, your view on the same two questions?
The first one is, when do you make temporal incision? I make when it is against the rule astigmatism. When it is against the rule astigmatism, them, I make a temporal incision.
Sir,
And
temporal SICS. My question is specific.
temporal SICS.
SS. Yes.
The
Okay.
difference between making a temporal SICS is between and from the superior orbital side is that here you have to remain close to the limbus, because if you go slightly away, then the tunnel becomes too long, and then if you enter into the anterior chamber early, then you will have iris prolapse. So you go about, say, 1 millimeter away from the limbus, you start the incision, and then you go into the making the tunnel in the same fashion. It becomes easy. There is no problem in that. And second question of how to extend, I always prefer suturing, or even if you don't suture a phaco incision, you can easily convert. If you fill the chamber with viscular thick, you can easily do a new tunnel and finish the surgery. Because if you go through the same incision of the phacoemulsification, then you would need suturing, as Madam has told. So that is very essential, that you make another incision, you will come out very easily without any problem.
And I have another question for you and ma'am both, sir. Do you think that there is imperative that we use a figure-of-8 suture at the end of our tunnels when we are doing SICS routinely, even if we feel that the chamber is well secure and it's a sealed tunnel, to avoid astigmatism?
Should I answer this?
Yes, yes.
Figure-of-8 is essential because when you go through the roof and floor of the tunnel both, and if you give a simple vertical stitch, then you are at the superficial portion only, and the lower portion of the tunnel, the incision slightly widens, and that leads to lots of astigmatism. So therefore, it is suggested that you make a figure-of-8 suture that will prevent the astigmatism from occurring.
Ragini ma'am, your take on this, whether we should routinely be doing a figure-of-8 or an infinity suture in all cases?
I have not taken sutures in all cases. Because there are two things. One is that the suture will be then buried under the conjunctiva. So if you want to remove the suture or do anything, then you cannot do anything. You are helpless. And we have routinely never taken sutures. One thing I would like to tell you is that some astigmatism is a part of SICS. But doing phacoemulsification also, even after toric intraocular lenses, you find patients do have on AR 0.5 astigmatism, but they can, most of it is compensated in day-to-day life. It does not affect them. So however, the suture itself, you are not using a tool to assess how tight or how loose your suture is till you assess that, and you can see this thing. So that suture itself may cause some astigmatism. I have never routinely sutured tunnels, but yes, if you feel that your tunnel, if at all there is a premature entry, if at all your tunnel, when you are making it, is not secure, at the end of the surgery after hydration, it should be a tense eyeball. If it is not there, for the safety of the tunnel, not for astigmatism, I've always sutured. But astigmatism control is not so much possible because there is sclera, there is connective tissue, the healing and the incision sag. So I have never routinely taken sutures in SICS unless there is some problem because of which I have to suture.
It's usually you apply suture only when the incision has become too long.
Yes.
And otherwise, normally you don't need any sutures.
Right.
99.9% cases we don't apply sutures. Only
Right.
when the incision size is long, then only we apply. A figure-of-8 is slightly different. This you go from the superficial portion of the sclera down to the floor of the tunnel that you have made, and then you come back again anteriorly and then from the other side you make a 8 incision, and then you tighten it.
Right, sir.
Okay.
Dr. Krutika, do we have any other question, Dr. Krutika?
More questions, ma'am. And one of the question is, what is the relation of size of peritomy and tunnel? Should peritomy be as small as possible? Conjunctival peritomy.
Yes, the peritomy should be just 1 millimeter beyond the incision that you are making. Supposing you are planning to make a 8 millimeter, 6 millimeter incision, then it should be just 1 millimeter on both the ends. Peritomy should be slightly larger, not much. It's because if you make a larger peritomy, then you will have more astigmatism, and you are unnecessarily touching the limbus.
I have seen the peritomy always little bigger, like I told you and like I showed you, because I find that peritomy starting at say from say if I'm left-handed at 10 o'clock. So not at 12 o'clock, little 1 or 2 o'clock, because if you make whatever peritomies are made at 12 o'clock or something like that, they retract with the lid. But if you are making them like a wood and just, you don't have to do anything. Once you remove the speculum or before you loosen the bridle suture, just pull the conjunctiva and place it there. It sticks like how the omentum sticks. And it remains in place. There is no scar. The patient doesn't look operated. So peritomy, it should not be very, very large, but more than large or small, it should not be saggy, friable, dirty. So if it is a smooth, clear peritomy, the conjunctiva will just go and stick back. And it will not even be seen afterwards that there was an incision. Some days later, you will not even find it, and you will not even find the site, and the patient looks like a phaco patient.
Yes, for bringing the conjunctiva back and depositing it there, finally you do a little bit of cautery, and there is a clue to that. Many people keep on pouring fluid and then they do cautery so it does not stick. It's always advisable to do cautery when the conjunctiva is dry. So then you will find that the conjunctiva will adhere with each other and you will be better off. So that can be done on both the ends, and that always is good, and the conjunctiva remains at the same place, and after 24 hours the conjunctiva gets well adhered to the tissues, and you don't need to bother about endophthalmitis. Why it is important to deposit the conjunctiva? It's just because you want to prevent the endophthalmitis. If your tunnel remains open, then you will have chances of some bacteria, some fluid, something wrong going through the tunnel inside and will lead to endophthalmitis. The chances of endophthalmitis increase if your conjunctiva is not properly covering the wound.
Perfect. Thank you
Yes,
so
sir.
much, ma'am. Dr. Krutika, can we
More
call
questions?
it? No further questions?
Yes, ma'am. There are a few more questions on YouTube, and one
Yeah.
of them is yes, ma'am.
Please ask. Ma'am, is
And
it
the question,
could ask a few questions more, Kamaljeet sir?
Yes, you can ask any
Thank
number
you.
of questions.
Thank you,
so
sir.
the question is how to manage if inadvertently an anterior entry is made into cornea, may it be SICS or pigmentoemulsification? How to manage it if we have entered more into the anterior cornea?
So if you enter into the anterior cornea, I mean, if you've gone more anterior, what will happen is your tunnel will be long. So there will be an overlocking effect. That's all. And you have to be very careful not to get Descemet strip or not to injure or hurt or cause a burn. So that's all that is going to be happen. And then the only thing is that whether you've gone too anterior or if you have gone less anterior and if your tunnel is short, then it may not seal. So you may have to suture it. But if you have gone too anterior, the only thing is that the tunnel will be very long and you will have an overlocking effect while operating. So operating will be difficult, but if the tunnel is properly constructed, it will seal. There will be some, injury to the cornea. That's all. And surgery for you will be difficult. That's all.
Yes, ma'am. And the next question is, what are the tips for astigmatism reduction in SICS? Is it dependent on length of internal incision also?
So, see, first of all, in SICS, the incision depends on the size of the nucleus. You think of astigmatism after that, because if you have a brown cataract and if you have a posterior subcapsular cataract, the size of the incision is going to be different. So like the video where I showed you, it was 4 mm because it was a small, it was a soft cataract. Now in a brown cataract, you don't want to do phacoemulsification because you don't want to damage a cornea which may be weak or specular count may be low. So here you are thinking of safety first and astigmatism later on. Here you need not go and increase the length of the tunnel, but by making the side pockets where the internal incision is larger, you can tackle a brown cataract also, but it will be larger. So like that, like suturing, if it is larger than suturing it. But I feel that even after suturing it, it will only help with the sag of the incision. Some amount of astigmatism will remain. So these are the situations where I am thinking of astigmatism less and the safety of the procedure and the patient. I want a clear cornea the next day. I don't want to damage the endothelium. I want the nuclear safety out with an IOL in place, with a patient 6/6, maybe with correction. So I am willing to accept the astigmatism. But for every patient, the construction of a modified from a proper triplanar incision and the distance from the limbus, a square incisional geometry for any patient is important in controlling the astigmatism and giving you least amount of astigmatism.
Yes, ma'am. I think that is the end of question, ma'am. That's it, ma'am.
Thank you, thank you.
Thank you so much, ma'am. And it has been great learning. Kamaljeet sir, thank you so much.
Thank you. Thank you so much.
Grateful for your support. Thank
Thanks.
you. We'll be soon joining you again for some of the interesting classes. I hope we keep learning from both of you for many, many sessions to come. Thank you so much.
Thank you. Thank you. Bye-bye.
I have my teacher and mentor, Dr. Kamaljeet Singh sir, here today with me because he's really a mentor and guru for me. And he's been
Thank
a
you.
teacher to so many
Thank you,
people.
Dr.
And he's a very
Ragini. It's always
close-
a pleasure. It's always a pleasure to be with you. And
Right.
thanks, Siddharth.
Thank you, Dr. Kiran and Dr. Kritika, for this lovely, warm class. And I'm so happy with the questions and
And
I'm
thanks to the young team of CFS.
Thank
We
you,
keep
sir.
on asking questions and keep on refreshing us. So it's wonderful to have you all.
Thank you, sir. And good night. Thank you, everyone. Thank you.
good night. Thank you so much. Thank you for everybody. Thank you to everybody. Thank you once again, Mahipal sir, Ritika, Santosh Onawar, and all of you from the CFS team. Thank you so much.
Thank you.
Thank you.